So I'm Kathi Kinnett with PPMD, and as people are coming up, first of all, I can't believe they made me follow Kent. I mean, I don't have any pictures of poop. There's nothing fluffy or bumpy going on up here. And I'm not sure we have anything that'll amaze you. Well, we might, though. Through PPMD's efforts and cardiac initiative, we've made huge progress in cardiac medications, in defining cardiac standards of care, in starting to collect cardiac MRI data, and a big study in looking at carriers and adults and cardiac function and what we can learn from those results. So we are honored to have 4 experts up here in all of those areas. And to start off, we're going to learn about pediatrics, and then from Linda Cripe, and then Dr. Ling is going to talk about adult care and carrier testing, carrier study findings. Then Conhor is going to speak about cardiac MRI results, and then understanding cardiac medications with Dr. Larry Markham. We've decided to do this session slightly differently, so I've asked everybody to try to condense their talk into about 10 minutes, and we'll see how good they are. And then at the end, we'll have time for questions. So as they're giving their presentation, think about what questions you've got for them. So to start off, we'll start with Linda Cripe.
Ooh, excuse me. Thank you. It's always an honor to be able to come to this conference. It energizes me, it motivates me, and it inspires me. And I get the honor of starting us off, and I think hopefully we'll have a really good session because we definitely have 3 other individuals who really know about cardiac care in Duchenne and in carrier moms. So I thought I'd start with this picture. Why should patients with Duchenne and Becker muscular dystrophy care about cardiac care? And I hope we all appreciate the little heart snowball, especially with those cactuses looming outside. And the answer is because the heart is a muscle too. And I think it's really important to appreciate this, especially in the context. I appreciate the fact that everybody focuses on the skeletal muscle disease because it is important, but the heart is tucked in there and it'll eventually need to be cared for. So what do I need to know about the heart? So before we can begin this discussion and before my colleagues will give you some important information, I thought we would do a little bit of a vocabulary beef up here. So a cardiologist is a heart doctor. There are adult cardiologists and pediatric cardiologists. Interestingly, we're similar but different. Pediatric cardiologists focus on the care of children with structural heart disease as well as acquired heart disease, and many adult physicians will focus on more ischemic types of problems with traditional sorts of heart attacks. Now there's a lot of crossover, and Dr. Ma is a specialist that does cross over those divides. But I think it's important to realize that not all cardiologists are the same. The atria are the chambers of the heart that receive the blood. There are 2 atria, and we'll look at a picture of the heart very shortly to describe how the heart functions. There's ventricles, which are the pumping chambers of the heart. There are 2 ventricles, both right and left. And cardiomyopathy, it's a disease of the heart muscle. And in Duchenne muscular dystrophy, children with this problem actually will go on to develop cardiomyopathy or disease of the heart muscle. Heart failure is an important term. I think it's a term that cardiologists throw around a lot. It can be very anxiety provoking because the word failure is there. But what it really means is that when the heart is no longer able to meet the body's demands. The word ejection fraction is also used very frequently. It's a measurement of the percentage of blood leaving the heart each time it contracts. Sometimes it's known as EF. People will say, what's my child's EF or ejection fraction? And fibrosis, and we'll have a lot of discussion about fibrosis during this session, and that's the scar tissue that forms as a result of muscle destruction in the heart muscle. Whoops. How do I go back one? Back is not as easy as forward. Oh, thank you. So here's a picture of the heart, and I think it's important to, before we spend the rest of the hour talking about the heart, to really understand how it works. So the blood returns from the upper half of the body via a structure called the inferior vena cava and comes into what we now have just learned is the right atria or the right receiving chamber. Blood returns from the lower half of the body via a blood vessel called the inferior vena cava and also goes into the right receiving chamber. That blood then goes through a valve into the right ventricle, which we learned are the pumping chambers of the heart, and that blood gets pumped to the lungs where it picks up oxygen and then comes back into the left-sided receiving chamber or the left atria, and it gets pumped into the left ventricle and then out to the body. So pretty simple. So blood comes back from the head, back from the legs, into the right pumping chamber, out to the lungs, picks up oxygen, comes back, and then gets pumped to the body. And so a key concept in understanding DMD cardiomyopathy is that as the muscle is injured, fibrosis or scar tissue develops. And here is a picture of a pathologic specimen, and you can see that white area is scar. And in Duchenne muscular dystrophy, the scar occurs in a very characteristic location in what we call the subepicardial area. And this will become important to some of the other speakers' talk today. There's a pathological specimen that you can see on the right there as well that's stained, and that blue staining is the fibrosis or scar tissue. And this is really an important concept, and I think it's important that if you take away one slide from my talk, this is the slide I'd like you to take the information from, is that the scar tissue forms in a very characteristic location that's very different than if you or I had a heart attack. So this fibrosis can be seen on cardiac MRI, and I'm not going to steal Dr. Hoare's thunder here, but I just thought I'd introduce this concept in that this subepicardial fibrosis or scar tissue is easily identified on cardiac MRI. This fibrosis starts in the subepicardial area or in the outside region of the heart, like we just saw, of the top part, and then it extends down to the pointed part of the apex and then up the septum. Importantly, this scar tissue is present prior to the decline of function and early in the disease. And I think those are important concepts that we've learned over the last 10 years. Those are things that are new to us. Of note, this subepicardial enhancement is also seen in myocarditis or inflammation of the heart muscle due to other types of infections. So it begs the question, are there similar mechanisms at work both in DMD and in infections of the heart muscle? So how should I care for my son's heart? So this past January, this document was released to the public, and if you don't have a copy of it, I think it's definitely worth obtaining. It's the cardiac care considerations generated by the Center for Disease Control, and in there's a section on the management of the respiratory, cardiac, and bone health, as well as orthopedic management. This diagram is taken from that document. I don't want to spend too much time on it, but what it essentially says is that at diagnosis, everybody should see the cardiologist for several reasons. One, to make sure that there's not any other underlying structural heart problems that may predispose issues to your child as they grow and develop. It's also important to get to know the cardiologist and have important discussions with your cardiologist. The cardiologist is going to be very important to you on your son's journey, and you might as well get a meet and greet on day one. After that, the annual exam is recommended with regards to an electrocardiogram and some form of non-invasive imaging, depending upon your son's age and the institution that you're being followed at. That'll either be an echocardiogram or a cardiac MRI. As your son advances in age, we recommend the start of cardiac medications such as ACE inhibitors, which Dr. Markham will speak about shortly, at about the age of 10. Prior to any significant cardiac surgical procedures, we do recommend a cardiac evaluation, and this is in particular scoliosis surgeries or large orthopedic surgical procedures, because we want to make sure that the child's cardiac health doesn't impact the outcomes during those surgeries. One last slide, or one last point that I would like to make before I turn it over to my colleagues, is chest pain in Duchenne and Becker muscular dystrophy. I think we're learning an enormous amount about this, and we're really on the cusp of some important understanding. So chest pain is frequent in the patient with Duchenne muscular dystrophy, and is often blamed on chest wall pain. If your child goes to the emergency room, it will often be dismissed by a pediatric emergency room physician as probably related to the muscles or the ribs. However, and a formal cardiac evaluation is rarely undertaken. Sometimes we get an EKG, and a troponin I, which is a marker of myocardial injury, or a blood test that we do to say that the heart has been injured, is rarely obtained. We do know that the troponin is normal or minimally elevated in baseline in Duchenne muscular dystrophy. So we we hypothesize that in the Duchenne cardiomyopathy, the elevation of this troponin MRI that we see in children with chest pain results from sort of this episodic muscle injury rather than continuous ongoing injury, and that there's silent and recurrent events that are leading to this injury. It's a process that occurs probably very similar to that in skeletal muscle. And this suggests a stepwise model of disease progression as opposed to a linear one. At this point in time, we don't know if there's external triggers such as viral infection, stress, or other illnesses. And the point I'd like to leave you with regards to this slide is that the majority of chest pain in your children is probably truly, I pulled the muscle, I had a difficult transfer, I have a little anxiety, and it's nothing, but chest pain does need to be a little bit more thoroughly evaluated in instances where it's significant and the child is definitely giving you as a parent a message that there's a bigger problem going on. So thank you for your time today. You know, I truly believe that care for children with Duchenne muscular dystrophy is a team sport and that we can achieve better outcomes with the breakdown of these silos and giving each other a big group hug. And the cardiologist, I think, is an important person in that team. So at this point, I'd like to turn it over to Dr. Ma to hear about the cardiac carriers and cardiac health in the carrier.
Well, good afternoon, everyone. I'd like to thank PPMD for the opportunity to speak here today and share some information and really looking at what we're learning about cardiac MRIs. So I think, you know, as Linda suggested, well, really why are cardiologists interested in this? This is, my son actually at lunch just asked me, I see a lot of boys in wheelchair, so why are you here? I think it's an interesting question, really, and I think I told him was that really the heart is a muscle. I mean, it's really one of the most active muscle we have, and it doesn't rest, right? It doesn't stop. So it's an important aspect to understand that it's under stress constantly, no matter what's happening to you. So a brief background here. So back in Duchenne muscular dystrophy, has a really universally developed cardiomyopathy. Really the big issue is when does it happen? And as you know, deficiency in dystrophin protein is lead to both skeletal, respiratory, and cardiac disease. These are all really pretty much interrelated. So we know from steroids that treatment does offer hope in many of the trials that are going on. To me, it's really exciting to see over the last 5 years and all the changes that have been involved. You know, so over the last 20 years, corticosteroid has slowed the progression of skeletal muscle disease, and the respiratory care, yay for the rest of the pulmonologists, has improved survival. So as such, the leading cause of death and morbidity has really been associated with this cardiomyopathy that Linda mentioned earlier. So why do we need to understand cardiac natural history? So cardiac care, as you know, is lagging. We use a lot of adult-related stuff, and Larry's going to give you some good information. And mortality frequently is associated with cardiomyopathy. So improved treatment really requires a better treatment strategy. However, the barrier has really been a lack of a way to look at how your treatment is effective. So it's not very sensitive or specific, and we need something like that to be able to help us look at the efficacy of our treatment. So what we know currently is the myocardium is dystrophin deficient. Cardiac disease is present at birth as shown by EKG, and disease progresses over time, as you can see by the changing from the normal heart function to the abnormal function, and really you can see this by non-invasive imaging. It is a major contributor to disease morbidity and mortality. So how will we look at the heart? Well, you can look at for structure and function, as Linda mentioned earlier. We can do this traditionally by echocardiogram, and more recently by MRI. So traditional assessment has been by cardiac echocardiogram, and it's great. It's available. It goes to you. It can be done fairly quickly. It's a first-line tool, and should be continued to use. However, unfortunately, as your child gets older from treatment, from age, it gets really harder to see because ultrasound beam cannot penetrate that. And echo is a good tool, but it really looks at how the heart squeezes globally. So I'm going to hopefully detail some information on that. So you can see here in the top panel here is a young boy with Duchenne muscular dystrophy. You can see that the images are pretty decent. Heart function is normal. Unfortunately, the bottom screen here shows a little bit of a blurred image, but really difficult to see. And this is an older boy, and it's hard to say how well the heart's functioning. Now, I'm obviously exaggerating this a little bit, but it is not an uncommon picture to see. So cardiac MRI kind of came into play, and I would credit Linda and the team, including Larry here, really, as well as Kathi, at really bringing MRI and asking why we're not doing a good job with assessing function. So there are many, many ways to look at this. I'm going to really focus on three major things here. Traditionally, ejection fraction, what percentage of how it's squeezing, and then LGE imaging or scar burden imaging, and then myocardial strain, which is a good way to look at contractility, how well your heart squeezes, but beyond that, looking at really the muscle level. I'm not going to talk about the other parameters just because there's not enough time here. And there are some disadvantages. Some of the boys can tell you, they do need an IV for scar imaging. It does take a little longer, although our institution, from the time we started in 2003 to 4, taking about 90 to 100 minutes, now is about 35 to 40 minutes. So we've decreased the scan significantly. The boys could hold their breath, would be great, but if not, you need to lay still. Although it's less available in the echo, it is changing. So you can see here on the screen left here, normal function with abnormal function. The images on both are equally good quality. Now, you don't want to catch the abnormal function part as the first time you scan a patient, right? Because by then, you're kind of walking off that cliff, and there's not going back. I think as someone mentioned earlier, when your muscle dies, you cannot bring that back. So now I'm going to go into the details of what some of this information here. So ejection fraction by MRI or by echo assess the global state and how well your heart is squeezing. So I'm going to share this through a grant by PPMD and helping us look at the immense amount of data we have and hopefully help you tell the story of what the heart looks like through MRI. So the purpose of the study is to really collect and make available comprehensive data and to inform the natural history of cardiac disease, to allow cardiac disease progression modeling and potential develop markers of disease and rather than symptoms. So you can see here, this is a publication by one of our fellow, Dr. Tandon here, looking at cardiac natural history. Although there's one thing you can see that there's a lot of jagged edges on each one of these studies, but what you can see is on all the signal there is a continuum of going downward, that ejection fraction changes over age and time in these boys. You can see here, and it gets worse with age. And this is kind of new data here that's what I've been looking at here. So as you can see on the panel on the left side here, that ejection fraction does not typically decrease up until around about age 10 or so. However, it becomes much, much more common with age. You can see the number of boys that are under that. And if you take a consolidated group here from age 5-7 to about age 21, you can see that the graph of the number of patients with ejection fraction abnormality using a fairly blunt tool increases substantially. So meaning that by the age of 21, a fairly large number of boys will actually have scar. This is based on current traditional treatment. So you can clearly see that all the treatment's good, it's not doing everything that needs to be done at this stage. All right, so cardiac function by ejection fraction can track function over time. It provides a mean to assess cardiac disease progression. It provides the ability to assess therapeutic efficacy, and it provides a means to determine cardiac natural history while patients are on traditional therapy. I'm going to shift a little bit. That EF is really a good gold standard we use. And unfortunately, it's a late finding. It happens a little later by age 10 is the earliest. And even in patients who are age 15, EF can still be very normal. It only happens when the heart no longer squeezes normally. So the question we've been asking is, are there ways to better look at how the heart squeezes? So since Linda introduced some of this, I'll kind of go over this a little bit. So it is a very unique pattern that it's in the subepicardial, on outer surface of the heart, is surrounded by the pink images. And then on the gross specimen, histologic specimen, the white and dark area. This is in contradiction to patient with heart attacks, where it's on the inside of the muscle. So this paper was published early on in 2007, and really we knew that scar happens when patients had abnormal function. We found some patients who actually were young, had normal heart function, and really questioned, did it precede the presence of dysfunction? Is it an early precursor of cardiomyopathy? So this led us to look at a really large population of the boys that we've been scanning, and we found that 17% of the boys that are less than age 10 had scar, and the youngest was 6.5 years old. Now, if you ask us about 5-6 years ago, we would have kind of raised an eyebrow and wouldn't believe you, but there's clearly evidence of that. 34% of the boys by age 10 to 15 have scar, And by the time you're about 15 years old or older, upwards of 60% of the boys have scar. Now, if you flip the other way around and say, well, what if the heart function is normal? Well, about a third of the boys with normal heart function by ejection fraction greater than 55% actually have scar. What happens when your heart function goes down? It's almost more than 84% of boys have scar. So this is a graph, a scatter graph of all the boys together. The blue squares are patients that don't have scar, and the red squares are patients that have scar. You can see that, not very surprising. If you're older, your heart function is down, you have a lot of scar. Not very surprising. Now, to me, really more important is that scar is really present in young patients, and it precedes abnormal function. Okay, so you can see here that in this second part of the natural history study, patients with myocardial fibrosis or scar have worse ejection fraction. More areas of scar leads to abnormal function, and more areas of scar happens as you age. So there's a threshold where if you develop a certain amount of scar, your heart function starts to decline. So I'm going to kind of finish this with looking at heart function beyond ejection fraction. So as I said earlier, EF is a good assessment of global heart function. However, as you can see, that scar is not everywhere. It's in certain area there. So unfortunately, ejection fraction takes everything together as a wholesale, and it's missing these. It actually conceals disease. And as such, it's not an ideal index of contractility, and it lacks this ability to look at regional disease. So you can see here that can you look at a different way at looking at heart function here? So if you kind of take a look at this graph here, it shows you that you can actually, using a very specialized technique, which I'll show in a little bit, you can actually look at different areas of the heart and actually show dysfunction in those areas. So why do we need to look at myocardial strain? What is myocardial strain? So it's a special technique that looks at heart muscle contractility. Ejection fraction, as Linda said, is the percentage of blood that gets ejected every time it pumps. Contractility really truly looks at the heart muscle movement contraction. So strain allows better, earlier detection of disease. By doing this, you're really changing the paradigm of treatment from rescue to prevention. So this is a quick looking at the concept of strain here. So if you kind of look at this, ejection fraction, everything we do, such as displacement and velocity, is motion. Okay. Now strain, look at myocardial deformation, what the heart muscle is actually doing. It allows you to look at the contractility. Positive strain is stretching as the rectangle is getting longer. Negative strain is shortening as it gets shortened. So this data here shows that the ABC on the right, on the red square rectangle, all have normal heart function by ejection fraction. On the other hand, the patient that is young, less than 10, and patient older than 10 with normal ejection fraction have lower strain. So the lower strain magnitude, the worse your function is. By the time you develop dysfunction and scar, your strain goes down significantly. So this study we published really allowed us to look to kind of overcome some of the issues of really non-sensitive tools, such as ejection fraction. We also looked at this over time and really show that strain continues to decline over time, whereas ejection fraction kind of declined generally, but in some patients, such as in the red and the blue, actually increases despite having no treatment changes over that time period. So myocardial strain really detects early cardiac abnormalities, and further decline in strain magnitude with age despite normal ejection fraction. Reduced EF results in further strain magnitude decrease, and development of fibrosis results in further decline in strain. So what do we learning from cardiac MRI? It really provides us evidence of disease in a population really with no way to routinely assess heart failure symptoms, provides the potential to create biomarkers of disease before the heart no longer squeezes normally, provides me to assess therapeutic efficacy, and provides data for cardiac disease modeling. So what is planned for this data? So we've been working with PPMD in putting all this data together. It's a lot of information here. And we're really trying to work with academic and industry partners to standardize cardiac disease assessment and work with industry to look at tools, how best to look at your treatment. So if your child's going through the process of this, we should use the best tool possible to assess the therapeutic outcomes. So imagine that one day you can look at PPM website or some website. You can plug in your child's age, perhaps genetic information, modify a gene, current treatment they're on, and imagine being able to know how severe your child's disease is compared to boys of the same age, same type of mutation and treatment. If the plan goes as well, which we hope, will help you actively manage your child's cardiac disease, gives you and your doctor an effective way of looking at your treatment compared with other boys, and really gives you knowledge that can change the outcome of disease. So, thank you.
Oh. Oh, there we go. Okay, this is Dr. Ling, who's an adult cardiologist and part of the carrier study.
So I guess this is the most anticipated talk, I guess, of the entire session. So I am at Nationwide Children's Hospital along with Linda and Con. I want to give you some background as to who I am and kind of how I got here. So Linda, Larry, and Con have a long history. They were in Cincinnati together. I won't say how many years ago. Larry still looks very young. So, I think they were all together in Cincinnati. And so what happened was Linda and Con came to Columbus. Larry went to Vanderbilt and then made the very wise decision of hiring me. So 5 years transpired. And I showed up at Nationwide Children's. And so something really interesting happened. This was about 4 years ago. So Linda approached me and said, hey, there are these moms in my clinic, and, I'm seeing their sons, and they keep having these crazy stories of, they have this, or they had a heart attack, but their cardiac evaluation was normal. Can you see these women? And I remember saying to her, well, I got 3 kids. I'm really busy. I just started this new job. I've got a couple of other studies going. I'm a plumber. I take care of kids with holes in their hearts, with bad valves. I see pregnant women with heart disease. I'm not sure I have the bandwidth for this. And so I guess my one disclosure would be I am not a Duchenne's cardiologist. And I think that at first I was like, I'm not going to do this. You really want an expert to do this. But the reality of it is, I think when you come from taking care of the boys, 100% of people I've seen take care of these boys fall in love with them. And so you're never going to move away from that. And so maybe you really actually don't need an expert. Maybe you need a new advocate. And that new advocate essentially focus on the moms. And so now, while I know that the talk says it's adult cardiac care and carriers, I am solely going to talk about carriers. And I think that in some regards, you have to change focus a little bit and not have somebody who grew up in the pediatric cardiology, and now I am a pediatric cardiologist, but to not grow up having taken care of the boys and transition into taking care of the moms, because that ain't ever going to happen. So I think the next logical step would have been this, which was that Dr. Markham come to Columbus, and I tried very hard, and he's laughing, but I'm absolutely serious. I tried very hard. Unfortunately, that didn't come to be, and he is now in Indiana, which means the people in Indiana just won the lottery in terms of Duchenne's, but we will still keep working on him. So I add this slide because I think that when you talk about carrier disease, it is by definition kind of loaded, right? We get from our parents both good and bad. So my brothers and I got our excellent fashion sense from my parents. My brothers actually, unfortunately, got their hairline from my dad. I got the stubbornness, I think, kind of out of all of us. But we get the good and the bad. And so I'm going to start with that acknowledgement, even though generally this goes at the end of a talk, because I have to acknowledge that this is hard. This is not an easy place to be. I mean, the idea of carried disease, something that you gave to your child, is by definition loaded. And I think if you don't say it out loud, it's the elephant in the room, and so I'm going to say it out loud. So I think that despite this, the miraculous thing is we started this carrier study a couple of years ago, and we've already tested 100 women. And so the fact that women are willing to come and do this, and it is a little bit of running the gauntlet, frankly, and I'll show you kind of the study design. So the fact that 100 women have come to do this is nothing short of a miracle, and it has to be acknowledged. So this is what we think we know. So oftentimes, and so this goes back to data kind of published late 1990s, early 2000s, that basically tells us that we do think that there is disease, and for the most part it appears to be mostly cardiac in terms of what can be defined. The problem is we haven't really defined the cardiac disease. So far we've been using echo. I'm an echo person. I love echo. It is not necessarily the right tool. And if you're looking to define a disease, it might be part of your armamentarium, but it is not the end-all be-all of cardiac disease. And that newer studies with newer technology, specifically MRI, we're starting to see that perhaps the disease is more common than we kind of once thought. So just to prove we're not making this up, there is kind of a genetic basis for somebody who has just one abnormal X having disease, is that you have two X's. And so for a long time, I think it was felt that, and it is true in a lot of diseases, that if you have one healthy X, that essentially takes over and you don't actually have disease. Unfortunately, that doesn't appear to be the case in Duchenne. So you have two X's. And the little X that exists in your cell that isn't being expressed can sometimes be expressed, and which X you express and to what degree really does appear to affect kind of what you're going to look like. It is also different kind of moms to daughters. They've done some really eloquent studies in terms of looking at this, and how you express your X is going to be different than your daughter, who is also a carrier that expresses the X. So there's a lot to be learned in terms of kind of moving forward. But there is a basis for actually having something to look for. So this is the knowledge gap, and I show this because when we originally sat down, and again, because I didn't come at this from a Duchenne standpoint, I thought, all right, okay, if we're going to really study this, we're going to study this. I'm going to do a randomized control trial. I'm going to put one arm on this med. I'm going to put one arm on the, and it was just, I wanted immediately to jump to treatment because we are cardiologists, and so at the end of the day, you want to try to be able to fix things. And so I started there, and then I remember Dr. Mendel got involved in the study and basically looked at me like I was crazy, because I was, and really where we are is we have to actually figure out what the disease is before we can move on to treatment, although clearly that's the goal. So where do we really start? So the major gap is you can't treat what you don't know. And so we are trying to figure out what it is. And while that drives somebody like me crazy, who I have no patience whatsoever, I know that that is actually truly the starting line. We have absolutely no treatment recommendation at this point because we have to figure out what we are treating. So step one, we really have to define disease prevalence and severity. It's going to give us the knowledge to determine the need and the type and timing of treatment, as well as how to monitor whether we're being effective. And so we are really starting in square one. So the impact of diagnosis. So pretty early on, after Linda approached me about doing a carrier study, we pulled in a psychologist, so Jamie Jackson, and you'll see her tomorrow in our panel discussion. Because see, the impact of a diagnosis is not nothing. So there's a positive and a negative impact to all of this stuff. And so we can say, great, we know you have disease, but the bad news is you have disease. So there's good and there's bad. I want to kind of keep an eye still, even though I know I can't get to treatment right now, but in part, keeping our eye on the ball is to say, well, if I can identify it early, it's a little bit like Comstock with MRI. The earlier I can identify it, we are really talking about preventing kind of actually, looking like you have disease. You need to continue to stay healthy. And so, is there a role for heart failure treatment in this population? What actually makes it worse? Is it your age? Is it acquired disease, like the run-of-the-mill cholesterol, diabetes, like things that people get as they age? And I can't ignore the fact that there is going to be impact in terms of you being caregivers, full-time caregivers, and the stress that's going to go with that. And stress certainly has been demonstrated to be a cardiovascular risk factor. And so when you put all of that kind of in one bucket, we had a lot to look at. And so we started with the Venn diagram, and of course cardiac disease is going to be the biggest one because the cardiologist made the Venn diagram. So, but if you look at it, we started looking at all these things, and all of the case series and stuff were written kind of in isolation, right? I mean, you can find papers in one bit, and then another bit, and another bit, and this was wholly unsatisfactory, and so what we did was we said, okay, well, if we're going to really do this, let's, go big or go home, and so we decided, let's do this, and then obviously we're very generous with PPMD, and they came in and supported it, which is, again, nothing short of a miracle. And we were able to kind of put this Venn diagram and move it together kind of with all the bits and pieces as it has to be. And I think that I don't have to sell that to anyone in this room. Like, it really has to be kind of a whole picture. And so this is the carrier study team. And while I would like to acknowledge everybody in this group, while I get to stand up here and present it, it's everybody in this group has really been working hard to kind of put together this study. This is a big team, and I'm leaving people out even so. So we kind of, take this whole picture, and I still do think that the big circle, even though I'm biased, the big circle really is still cardiac disease. And so we talk about kind of heart failure and the focus on that. And so I'm going to go kind of into cardiology, and we'll back up again a little bit. So Linda already talked about what is heart failure. It's really complicated, right? I mean, the heart fails to meet the needs of the body. And I think that you can just distill it down to something so simple. It doesn't mean that it's actually failed or stopped. Like, we were all science majors. We were not English majors. Like, we probably wouldn't have chosen the word failure, or we didn't appropriately choose the word failure. It just means that, the heart is starting to have trouble in terms of kind of maintaining all of its functions. It can occur when cardiac function is poor, but it can also occur when it's normal, and that's complex. And the body's response is at first helpful, but eventually causes harm. And so there's a huge cascade of things that kind of all come into play. And so again, this is yet another kind of multifactorial thing to look into. So prevalence of carrier cardiomyopathy, so specifically the heart disease, is, you can pull studies, and anywhere from like 9 to all of you have some sort of disease. So it's 9% to 100%, I think, when I pulled up the papers. And in part because nobody has a singular definition of what constitutes disease. Are you a manifesting carrier, or are you non-manifesting, and by what way are we going to define that? And so I would probably disregard any number you see kind of for the moment, because it just depends on how we look. So how is our study different? And so what we've tried to do is design a large case control study. And so we're aiming for 100 carrier moms, 50 non-carrier moms, in other words, without the genetic mutation, but still moms of boys with Duchenne, 25 carrier non-moms. And so this is a newer group that we're focusing on kind of recently, in that usually what's happening is it's the sister of a mom. And so I think that answers different questions, but interesting questions. And then 25 healthy controls with normal CKs. And we took those, actually, they're all employees at Nationwide Children's Hospital who responded, and they're it's age matched. It's a longitudinal design, so the anticipation is that we collect 3 to 5 years of data. So once a year, we send the women through the gauntlet. And the control population is to look for just what is normal. We don't do a lot of this testing in normal women, and so we felt that was important. It's a holistic look at the patient, and so it's necessarily interdisciplinary. Treadmill testing has not been done at all in carriers, and we'll go into that a little bit more. And then technical improvements, we actually left the echo behind. So all of these women are getting cardiac MRI. So carrier cardiomyopathy in the past and other studies has been defined by cardiac enzymes, echocardiogram, and MRI. I think these first two are essentially off the table. It's kind of a scatter plot in terms of kind of what you can actually find from those two things. And so we are doing cardiac MRI, and then we're adding exercise treadmill testing. This is the first test of functional status in carriers. And so I think most of you are familiar with the 6-minute walk. Exercise testing is kind of like 6-minute walk on steroids. And so I'll show you. Let's see. So the study visits, there are 3 study visits completed over a course of 2 days. So there's day 0, year 1, year 2, so 3 total years, or 3 total time points. Each time point consists of the following components, and you just look at that, and we really do send people through a good amount of testing. Day 1 is focused on kind of the cognitive testing, neuromuscular, and physical therapy assessments. The patients, when I see them on day 2, love to tell me about the time to rise. They get to kind of go through some of what the boys go through, and so that's not so bad. From a third-party perspective, not so bad. Day 2 is the treadmill and MRI. So enrollment thus far, so we've had, like I said, about 100 women tested, 54 confirmed somatic carriers are all getting genetic testing, 20 are confirmed non-somatic carriers, in other words, they don't have a gene defect, and then 26 healthy controls. We added a healthy control for a lot of reasons, but so we have 26. I ran the interim analysis in March. We just did a stop and let's see what we have so far. And so at that point, the numbers there are what we had at the time, of the numbers that I'm going to give you. So treadmill exercise testing, you may have heard of it in terms of using it usually to identify someone who's had a heart attack or to screen somebody for heart attack type stuff. We're not looking for that in carriers. We don't have the suspicion that that's what's going on. The 6-minute walk, I think that these women are too functional to get a 6-minute walk. So if you exceed, it depends on your effort and all of those things. And so we needed kind of a higher level test to actually push women. An exercise gives me a lot of good information about your functional capacity, your hemodynamic response to exercise, so that's your heart rate, blood pressure, that type of thing, and actually your effort. So I can tell if you gave me a full effort. So this is what it looks like. And so these two women are part of the study. So Michelle Slowinski is the woman in the gray t-shirt. She's our exercise physiologist. She's amazing. She's also in love with you all, in love with your boys. And so she started on this project as well with us. And so she's been doing 100% of the exercise tests. The woman in the picture is one of our cardiac nurses, and she volunteered to be our model for this. And so we set you up, we hook you up with an EKG, we put that beautiful face mask on you, and then usually people take out their phones and take a picture at the time when the mask goes on, and it's usually posted to Facebook before we even get on the treadmill. So then you run, and as you run, we collect data. And so these are a picture of the two of the screens, so EKG on one, and then the measurements coming off the mask on the other. So this is what it looks like. I mean, it doesn't look so different than a regular treadmill, except for all the equipment around you. And so it goes through, and usually, ideally, we like to get you about 9 minutes. And so it's usually the setup. When we set up for like an hour, it's mostly kind of set up and kind of cool down stuff. So I don't put the mask on people just to torture them. I do get some information from it. And so what we're measuring is your oxygen consumption. And so how much oxygen can you use during exertion? This is a very good indication of how your heart, your lungs, your blood vessels, and your muscle work together. And at the end of the day, it's recognized as an indication of someone's personal fitness level. So how much energy does your body give you to do the exercise? And so that is essentially the gold standard for kind of a functional capacity personal fitness level. There are other measures that fine-tune it more for a cardiac-specific measure, and then there's a measure of effort. Did you give me a full effort? So our average age in all of the groups, the controls, the moms without genetic mutations, the moms with genetic mutations, was about 42. Age range was 28 to 63, and was not different between the three groups. So when I look at that personal fitness level, so there was no difference actually between the moms with a genetic mutation and the moms without a genetic mutation. You did about the same. And so and this is not like a perfect measure, right? But in looking at it, they were not particularly different. There was, however, a big difference noted between the moms and my control patients. And so it was almost a full standard deviation. And so it was a pretty big difference. Now, those numbers were pretty respectable. It was about a 28 in a woman, which is going to be kind of on the low side of okay, but low, and about a 35 in my control patients, and so, which was about average. And so it's not like, all the moms were couch potatoes. Like, it was actually pretty good, but it was still on the low side and different. So what it means is being a mom meant that you had a lower general fitness level compared to controls. There is clearly going to be a lot of unboxing to that statement. And so I'm going to say that, and I put a big star next to it because I can give you the numbers. I can't tell you why yet. And I think we are still going to look into that and kind of try to tease some of this out. So there was actually no difference in the cardiac specific measure, though, and I thought that was pretty amazing. So it was equivalent to my control moms, and so both the somatic, the non-somatic, and the controls were all about the same. So the heart did not appear to be the specific limiting factor, and this is all preliminary, though. And so as we run more and more women, and as we do kind of longitudinal testing where we're doing kind of year 1, year 2, year 3 stuff, I think we're going to be able to find out more. And everybody gave me a full effort. So, I joke about having to measure it, but everybody gave me a full effort. There was one finding that was unexpected, and I'm going to tell you about it. And again, it should be caveated that this was all preliminary kind of look and interim analysis at the data we have so far, is that women who were genetic carriers did show me more heart irritability. And the way they showed me that was they would show me these early extra beats that none of them ever, and for the most part, you think of those as fairly kind of normal things that you see once in a while, but it came out as pretty substantially different. Half of the women with a genetic mutation actually showed me these early beats during exercise. This has been demonstrated to be associated with heart irritability and other cardiomyopathies, and so I am looking at this kind of more carefully. We're going to go back and look at the analysis in terms of when it happened, at what stage, was it at peak exercise, was it in recovery? Like, we're going to try to figure some of that stuff out. In year 2, so in repeat testing, I had a couple of women who actually strung those early beats together, and it looked like a bit of a more concerning pattern. But in year 1, nobody had a particularly concerning pattern, just that it was there. We are going to try to correlate that arrhythmia piece with some of the MRI findings that Dr. Hoare is working on. So this is the MRI, and so again, they go through that, but I left that to Con. He was supposed to go after me, obviously, and then myocardial fibrosis pattern that both Linda and Con alluded to has been demonstrated to look just like the boys on MRI in the carriers. So it's that same pattern. And so the women who have come to me and said, well, I did have this heart attack, but they never found anything, they don't have heart attack scar. What they have is Duchenne scar. And so that, I think, is an important finding. The results on the carriers in terms of the MRI was that the ejection fractions, that squeeze number that we were talking about, was no different between our control patients and the DMD moms. However, half of the women also had fibrosis on MRI scanning in the pattern that a Duchenne's patient would also have that fibrosis, and so that's rather remarkable. There was one woman who was actually a non-genetic carrier mom who also had scar. So that is interesting. Aging is rough. Age matters, and so when you compare the groups that did and didn't have scar and didn't have arrhythmia during the treadmill testing, they're on average older. The stress biomarker part is still kind of in process, and Jamie Jackson will be here tomorrow during our panel discussion to discuss some of that. And we're trying to link some of the findings we're finding in terms of the MRI and the treadmill testing with the stress. I have to acknowledge PPMD for supporting this study fully. The Heart Center Research Program also supported this study in terms of paying for all of the control testing for us, and so without these groups, we wouldn't have been able to pull this off. So I go back to the things we carry in terms of my final slide. I really am in awe of the people that I've met kind of in doing this study. This is an incredibly dedicated group of families. And I think, if you're going to pass on the good and the bad, one of the things that I see in all of these women is an incredible resilience. The fact that none of these women petered out, like they all gave me a full effort, is something really to be proud of. This may or may not come out in the data, but it is absolutely true. And probably is the most important thing you all will pass on to your kids. And so I'll just end with that.
So as Larry comes up, I just want to remind everybody that if you're interested in a deeper dive into the results of the carrier study, that the carrier team will be available tomorrow at lunchtime to go over those study results. So last we have Dr. Markham, the lottery prize for Indianapolis. So, sorry. Well, there they are.
There's one.
Just one representative. I think you're up. Thanks.
So it's always an honor to present before you, and as a physician myself, it's very rare that I'm in a room or on a podium where I think there are 3 other people who could take care of my kids better than me from a medical standpoint or a parenting standpoint, and this panel would be one of them. So I'm humbled to be a part of this panel as well. So we'll blow through some things about cardiac medications, and really here's the outline. We're going to talk about, just briefly touch on what is the risk, and the most important part of this is outlining a treatment strategy approach, prevention versus rescue, and then we'll go through some of the medical treatment options that you may or may not have heard about. So as Con and Linda and Mei Ling alluded to, we're really treating ventricular dysfunction, and that is signaled here by an ejection fraction, and we know that it increases with age. And so I'll go back one and say why are we treating that is because we know that ventricular dysfunction impacts survival. So if a boy has poor function compared to a boy with normal function, their life expectancy will be different. But as Con showed, a picture is worth 1,000 words. And so you see on the top is a picture of an MRI with a boy with normal function In the middle is moderate ventricular dysfunction. And the bottom, yes, it is playing, is a heart that is not squeezing very well at all. And that's what we're trying to treat. And so, as I mentioned, the treatment is trying to impact survival. And so our approach is one of prevention or rescue. And you think back when you were a child of taking swimming lessons, you were trying to prevent a drowning. And the same thing is true with using smoke detectors, using appropriate plugs and sprinklers in your home. You are trying to prevent a home fire. And so if you think of a medication that we are being used to prevent a condition, you would like that medicine to have low toxicity, low risk, and you want to be able to take it for a long period of time. You would like to hope that there is potential benefit, and you would like it not to cost very much. But the problem with that is you have to treat a large number of individuals to really prove that it prevented something in the long term. If you contrast that to a rescue approach, so that no individual was harmed in the taking of this picture, this is a group of lifeguards who are practicing saving a dummy and a house that is on fire. So if you are faced with those situations of a rescue, you really will be able to accept more toxicity because you already have a particular condition. You'll also be willing to accept more side effects. You would like the length of treatment to equal the response. So the longer you take it, the better you are. You would want a drug or a therapy that has a definite benefit. You probably don't care about the cost as long as it works. And to prove that it works, you really only have to treat a small number of individuals because you know that you will see benefit. And so if we take that approach into different medications that you can be on, I've tried to outline the role for each one that we'll touch on. So ACE inhibitors are commonly used in Duchenne. I'll back up and say that when I gave a talk similar to this, I don't know, probably 15 years ago at one of the PPMD meetings, there was no evidence or data of any of these drugs in Duchenne. And I included references at the bottom which show that these medications have been used in Duchenne. And that's a phenomenal accomplishment over that period of time. So ACE inhibitors, the role is really both prevention and rescue. And as Linda mentioned, our belief is that everyone should be on one at some point in time. They have been shown to be beneficial. The really point of contention is when you start it. And that's a conversation to be had with your provider. They're generally well tolerated, and I've not had anyone that I've had to stop or change therapy based on allergy, cough, a potassium, or an exceedingly low blood pressure at the doses that we use. Angiotensin receptor blockers are another family of medicines which may relax blood vessels and also may have an impact on scar. Again, they're for prevention and rescue. It's largely for those who are intolerant of ACE inhibitors. Same side effect profile. There was one study which really compared the two of lisinopril versus losartan, and there wasn't a huge difference between the two given the limitations of the study. And so I think one or the other is appropriate. We've seen pictures of scar or fibrosis, and Con has done elegant work through the course of his career, really documenting that this is probably one of the first things that we see. And so in my mind, the role of prevention for these drugs is developing. Some people, and I'm starting to wonder, should this take the place of ACE inhibition at the first medication that we use? Or should they both be started at the same point in time? It certainly has a role in congestion. So if an individual already has ventricular dysfunction, it certainly fits in with the rescue profile. And we now have data largely from the group on the stage that there is benefit in Duchenne. Beta blockers, Ling showed a slide of the complex interactions of heart failure. So when your heart doesn't work, your body has an increase in adrenaline, and that adrenaline initially is beneficial. However, it's detrimental over time. It actually worsens scar, it worsens heart muscle function. And there are some beta blockers like carvedilol, for example, which may have a role in fibrosis in and of itself. If you look at beta blockade as a prevention strategy, I think there's really an uncertain role. For example, I have not prescribed a beta blocker for a young man unless we had other concerns with heart rate or heart rhythm in a prevention role, but it's certainly evolving. It certainly is beneficial from a rescue standpoint. So if an individual has already ventricular dysfunction, I typically consider it in all patients at that point in time. It's generally well tolerated. However, there's slightly more side effect profile, which again goes to using it early. You may have to be willing to accept a little more side effects. And we do have data in Duchenne specific that it's safe and efficacious with both heart rate variability as well as ventricular dysfunction. Digoxin is a medicine which is commonly used in heart failure. And we talked about calcium earlier this morning, but there may be some other roles for this neurohormonal cascade of heart failure. For Duchenne, there really is no role in the prevention, and it actually may be harmful because of this increase in intracellular calcium. And there is a possibility that it may play a role in severe heart failure and those with low blood pressure who are becoming intolerant of their ACE inhibition. So, however, again, the side effect profile is higher. There is a need to monitor levels and the electrolytes for patients, particularly potassium, particularly in combination with other drugs. There actually are some references. I found this and I thought it was when you give these talks, you find things. There was a reference in 1994 where boys with Duchenne were given digoxin to see how their kidneys cleared it from their body, and their ability to metabolize the drug was different than other individuals. So if you have a child on digoxin, it's important to monitor the levels along with kidney function. Diuretics promote loss of fluid through the urine. There's really no role in prevention, and it's really for those with poor heart muscle function and congestion and can help alleviate symptoms. There's a lot of side effects, particularly from quality of life and having to go to the restroom, but also electrolyte imbalance. And if you're wondering why there's a picture of horses up there, I'll talk to you later about that. So I think this is a set of images which I've modified continually with care consideration guidelines and probably have had a slide similar to this for the last 18 years since I've been involved in Duchenne. But I think I wanted to highlight the different stages and the treatment approaches. And so if you look at an individual who has a diagnosis of Duchenne and has a normal evaluation, which means normal function, no fibrosis, I think that's the time to discuss the pros and cons of beginning ACE inhibition or ARB therapy or a medication such as spironolactone or eplerenone. If a child is older than 10, as Linda mentioned, or there is structural disease, meaning there's scar tissue present, to me that's a time to act. And so you really look, if you're not already on a medicine, consider medications. If the doses need to be optimized, this is a time to do that. If you have stage C or you already have abnormal function, this is the time for the kitchen sink. We're going to give you every medication that we have in our armamentarium. And stage D is really those with very severe heart failure and abnormal function and symptoms. And so that's the more difficult patients to take care of. I've worked with the people here for a long time, and it's really an honor to work with them, as I mentioned. and it's a privilege to get to talk before you. So thank you.
We have just a couple of minutes, so if you have questions, it'll come on.
Thank you so much, cardiac team. Just thanks. I've got, just to clarify with Larry and Dr. Ma, medications. Just because some of the parents come, it's nice to kind of discuss. So in terms of fibrosis, the approach where I've been used to is if the function is normal and there's fibrosis, aldactone, as you've mentioned, you know, it's got a role in prevention as well as antifibrotic. So I think here it really would that be the first line if the EF is normal and you've got fibrosis, that you'll rather do aldactone first rather than an ACE, just because of the antifibrotic? Question for Larry.
So I'll answer it quickly. I actually do both because both ACE inhibition is shown to impact fibrosis and a eplerenone or spironolactone is. So if you have fibrosis, I'm not going to leave it at one.
But you start two at the same time?
Relatively soon, yes.
Thank you. And then, Dr. Ma, because the cardiac MRIs for the carriers, I know the publication that came out from the team at Cincinnati about a year or two ago was like about 25% of fibrosis and about 10% with LVEF down. And I think for those with fibrosis but normal EF, I know again the medication has been aldactone to treat. And of course, those with decreased EF, you know, that's the other medications. But so if I've got moms that come, so if they have got fibrosis in the study, it's a 2-year study, do they get treated or you just keep monitoring till year 2?
Well, we have not been treating. And I think that that's an important thing to say. I think that it's been clear by the natural history studies, and there have been a couple of studies in Europe that are just natural history studies in terms of death studies, that this isn't a race. And so we felt that it was more important to define the disease than to preliminarily treat it. Now, there are some people who come on treatment, and I don't generally change the treatment. And I'll say this, I have some women in my clinic who are not in the study that I do treat. And we can talk about the details of what I use, but they respond. And I was telling Linda this in the elevator actually on the way here, is I think the feedback loop is that it may be that the moms are going to be evidence in terms of how much dystrophin you need. These moms have some dystrophin. They have some functional dystrophin. And so I've had some women show up with EFs in the 20s, and that's pretty rare, but they show up in the 20s and they respond beautifully to standard heart failure therapies. So ACE inhibitors is almost always where I start. Spironolactone would be number 2. I do use beta blockers in the moms, carvedilol. And so those get started in fairly rapid succession, and I usually use a little diuretic, and that's a symptom thing. So you're put on 4 drugs pretty quickly if you show low EF. And I'll leave it to Con to kind of speak to some of the EF findings preliminarily in terms of what we're seeing.
So I think
It'll come on.
so the findings of the previous study, really show that most patients didn't have a lot EF many had EF below 50, so they were kind of in that low normal range. Again, partly because it's probably was a smaller study, you didn't really get as many patients. I think in our study, we showed some similar findings. There were some patients had EF that was in the mid-40s, and those patients generally were treated, and that's pretty typical for heart failure treatment anyway. I think what's unique about what Dr. Mahai presented is that actually there's the genetic confirmation of it. In all the studies were really not truly confirmed. They were just known to be, carrier moms, and they got labeled with that. And we know that in our study, patients came in with a thought of what they had, but actually a number of patients actually had the diagnosis reverse from coming and say, I'm not, to coming as they had, and vice versa. So I think that piece of data actually will add a lot to knowledge.
Thank you.
And I think a small piece to the eplerenone trial, I think it's important to know that eplerenone is a specific receptor binding and versus aldactone, which is actually non-specific, which is shares similar type as a lot of the corticosteroids. So that study just finished recruiting in 6 centers, and we're actually in the middle of making the analytics, hopefully showing that there is no difference between eplerenone or spironolactone, because the cost becomes substantially different. And you may be treating someone when it's only $5 a month versus a lot more. So I think that data would be hopeful in terms of one of Larry's comment, low cost, low risk becomes a much easier medication to treat.
And then one more. I have come across a patient on ACE inhibitor and got started on Bactrim, and then he went, into high potassium, which they wrongly diagnosed as adrenal insufficiency. So looking up, we see the literature of the contraindication of Bactrim when they're on ACE inhibitors. So I think that's something that we kind of discuss in clinic because, that patient did have that problem when, Bactrim. So it is out there that you don't use Bactrim and tell your pediatricians that, I guess, if that's something that would be put on for the cardiac literature or whichever.
Mm-hmm. Yeah, we can include that as well.
That's a good point.
Thanks, Brenda.
Hi.
Question? Hi.
Yes. With regard to these new methods of cardiac testing and imaging that are potentially more insightful, where are we with moving the dial to get these as part of standard of care in the certified centers?
So, I think the panel up here is a little bit biased in the fact that we have been doing this for, sad to say, almost more than a decade and a half now. I'm the youngest of the group, I think. But I think, our dial has been there. I think credit to Linda and Kathi and Larry. I think I was a young fledgling fellow when this all happened. So I think, our dial from our perspective is there. We have real-time assessment. So again, this is, when I talk to family, it's you guys are the, root of pushing things that we do. And I think I encourage you, and again, to kind of share data with people you work with. Now we have scans that are done, and if there's scar, there's change, Linda gets it real time. And then she knows what it is, and then she knows what it looked like last time, and she knows what it looks like, and I'm going to change it to Linda for 1 second.
Well, I think that in answer to your question, I think we're moving forward. I think cardiac MRI is becoming standard at most pediatric centers around this country because we're using it not only for this disease, but mostly for congenital heart disease, which is really driving the expertise in that. So I think, cardiac MRI is less taboo and much more available at most pediatric centers these days.
And does that give insight to the myocardial strain testing, or is that completely different?
Yes. So myocardial strain is really a way to look at your heart muscles contractility. At this stage, many of the reasons that it doesn't get put in routine use is just because it requires an additional type of analytic, and not many people do that. It's one of my focus, so therefore we do a lot of it. And hopefully, as we put this data together as part 2 of our natural history study, it's going to show that strain occurs earlier. So there are many things that we have looked at that I didn't talk about, from the T2 mapping, T1 mapping. These are ways to look at what's happening to the heart sooner. So I kind of akin this to, if you're trying to extract a diamond from a mine, I guess if you see something, you don't want to use a big giant hammer to try to break it open, right? You want to chisel that. You want to really get into fine details. I think that's what we're getting into. I think as I see this about 5 years ago, I think the cardiovascular imaging aspect was still evolving. I think we're learning more, and I think as more and more folks learn about it, you bring this to your own local sites, and eventually this evolves. We know that it takes a while for things that get into practice in one place to be nationally practiced. I think the paper that was put out in the, both have suggested early use of cardiac MRI. I think that is an important step forward to making that more available.
Thank you.
Other questions? I'm very thankful to everybody in my Duchenne village that I can call on and ask questions of, and I'm especially thankful for everybody on this stage. So thank you for everything that you do, and let's take a 5-minute break. right? And then we'll be right back.